hjärtligt välkomna hit till Transplantationssstiftelsens utdelning av stipendier och vår gästföreläsning. We start with a mix of English and Swedish, and because I know you want to see how much you understand our Swedish, which has some words that are similar. Vi har ju när man ska ha möte så har vi liksom en perfekt storm av bra tillgång till organ och ett mindre covid-utbrott som gör att det är därför vi ser till att vi filmar idag så att fler kan få vara med om utdelningen och av föreläsningen. Och vi har inte vi planerade det här mötet planerade vi till 2020 men ställde in det. Så nu gör vi 2 år senare istället. I vår stiftelse så har vi då som uppgift att främja vetenskaplig forskning och utveckling inom området för transplantation. Och även främja utvecklingen inom leverkirurgin. Och det är då företrädesvis verksamhet som utgår från Göteborgs universitet. Och som vi inom stiftelsen ser på stiftelsen så är vi ganska små, men vi är snälla och vi har lite dunderhonung i form av pengar som vi försöker använda på bästa sätt för att med de medel vi har få igång projekt som är i närtid kan ge nytta inom både leverkirurgi och transplantation. Vi håller ju dock, Bamse håller dock på att bli lite större kontinuerligt. Varje år så delar vi ut lite mer dunderhonung. I don't know if this is a famous Swedish cartoon. I don't know how if it has spread to Switzerland. I'm not sure, but his name is Bamse. Och det här är vi som är i stiftelsen här, där stödjer Friman som åker runt på Islands obild efter vårt möte där förra veckan på som du lägger på.
Han är på mottagningen.
Okej. Han kommer snart. På Magnus Wisell som är ansvarig för leverkirurgin. Ingrid, som de flesta av er känner också. Och Peter Forsmask som är den som hjälper oss att hålla ihop styrelsearbetet som tyvärr har covid han också. Så är det. Och det är de här som har fått dunderhonung. En del har gjort sina avhandlingar tack vare detta. Helena Hammarström och till exempel Malin Stenberg Lard. Och så att vi har nog kunnat fördela pengar så att vi får nytta av dem. Och förra året så hade vi också en ansökan och den delade vi ut till, där fick Jan Söfterland som har ett stort projekt på covid-19 hos organtransplanterade som kändes extremt relevant förra året. Så han fick inte vara med om en sån här ceremoni där, men fick pengarna istället. So then, and I mean 3 years ago we were in the process of starting perfusing livers, and we thought we need to get some knowledge about how to do it and how to start it. And then I had listened to you on several occasions at meetings, and we invited you and you accepted to come. And then I think the first wave came just a couple of weeks before we were supposed to have this ceremony. So therefore, I'm very glad that you have accepted to come this time. And since now you are working in Milan, Policlinico, at that time you were in Birmingham, but still you have been connected to, your research is based in Zurich, and we discussed yesterday how it's good you have only a two-hour train ride between your hospital and your university research. So we were out yesterday and tried to pick some of your thoughts about machine perfusion. I mean, before we all used the cold storage only, and that is not the future. It's something of history soon, I think, and we very much would like to get your thoughts about where we should go and how practical when we introduce. I mean, I checked, we have done 31 machine perfusions in liver so far during 2021 and this year. So we are on our way, even if we are far behind your experience and we haven't really evaluated the results yet.
Good afternoon, everyone. Thank you, Per. Thanks, everyone, for inviting me. It's a great pleasure to be here and to meet all of you and to see that you've done already 31 perfusions, which is actually a good number. And it's not so easy, the role of machine perfusion, that's the presentation. It's not easy to bring that in a short time because it's not a tailored thing for every organ. I have nothing to disclose. I'm supporting different studies clinically, mainly centers, and also during my time when I worked in the UK, I met so many people which are now back home in Brazil and everywhere else, so we support each other to get these things forward. I have a layout. I'll go a little bit into mechanism initially and then go a little bit into clinics. Where are we? What is really evidence we have? Because that's what drives us and why we should use certain techniques and why not. And then I have a last section on viability assessment, because that's the key probably also to increase higher risk organs and to decide then life what to do and what not. This is clear. Transplantation is a standard treatment. There's minor differences, you can see it in techniques, in suture, in anesthesia management, in some regions, but mainly it's the same, and we have reduced the number of transfusions we use, we have quick implantation times, we have a good outcome in the last 20 years has improved a lot. But the challenges are different now, and you see it on this slide a little bit. We have very sick recipients, we have new indications with more cancers, and we get frequently higher risk organs, not always as fatty as on that slide, but increasingly steatotic, increasingly old. And then we have also logistical issues. We have no beds. In Birmingham, for example, was a big issue with ICU beds. We had to postpone cases. I remember I had a month, and we were a program with 300 liver transplants a year almost, but we had months where we had to decline 10, 15, 20 organs because we had no beds, and even with machine perfusion there was no way around it. So that's our problem today. And here we see another problem. This is only DCD livers in the last 10 years, and you see the range of complications. For every type of complication you have a range, and one paper, for example, presents it in the lower range. I don't know if I can use this, probably, but one paper presents an ischemic cholangiopathy, like the one from King's College, with 3 to 4%, and then you have papers where you have 20, 30, 40%. And that is a problem, and this is clearly linked with the injury we have. For example, graft loss, based on biliary problems, 2% to 10%, clearly depending on the warm ischemia, for example. And this is valid for any of those outcomes. And what we do and what we accept is also linked to the waiting time, because I have patients in Italy who wait 18, 17, 20 months for a liver. So I have to explore these risky organs and have to see what happens. And if we ask in the room and worldwide, that's what we did in 1 hour surveys, we asked what do we expect? Yeah, we want beautiful organs, we want a repair, we want an improvement, we want no complications. Basically the holy grail of transplantation. And here you can see repair, improvement of function, and in the end it's a safety and a cost. issue as well. But the reality is this: we can preserve for a few hours, and we are not really able to reliably predict what we do, because we know it works. We know it works under these circumstances, and that's why we do it. And one problem is very elegantly described by Alexis Carrel, who also did the anastomosis technique, but he describes very well that with the organ donation, we are somewhere between life and death. And just by looking at the donor or at the organ, we don't know if we're here, here, or here, really reliable. And that is the problem. So we need to understand what's really going on there before we can do the right thing to the organ. And cold storage, Per already said that a little bit, is a wonderful method, and it works beautifully for many years. This is Volker Belzer from Wisconsin. You see all the experiments he did. All these folders are full of studies where he identified the best composition of the cold storage solution. It is certainly low cost, cheap, practical, easy and safe for standard grafts. And there's a new paper you can read about all these different features from this year. But the big problem is we cannot prevent the injury. We always have a reperfusion injury, even in a living donor kidney or liver graft. It's just less, but we have it, and we cannot do anything to get around it. This is interesting because if you go back to the literature, and I'll do that very often in my presentation, you can see that in 1991, published by the group of Thomas Starr, at that time, at least half of the livers were transplanted with more than 10 hours cold storage. Today, we are happy with a median of 7 or 8 hours. All these livers wouldn't be transplanted today. And accordingly, if you look at the outcome with increasing cold storage, of course, you get retransplants and more PNFs expected. But many people don't know, and they're not aware, and we start to get curious, can I do it? It has already 10 hours, it has already 12 hours. We are not used to that anymore, but they did it, and they had a lot of problems, but they did it. And this is essentially the key structure, unfortunately, for our surgeon, because we need to go back to school a little bit and understand. But the reason why we can do it is when mitochondria do a beautiful job. And they are able to recover what we do during ischemia. So when we remove an organ and put it in ice, or we have warm ischemia in DCD donors, we get a problem. And it's essentially 3 problems. No energy, and a lot of enemies accumulate. For example, succinate or NADH accumulate. Because it's like an electron flow doesn't flow anymore, and all these system is on hold. And everything else is consequences. But the key is this, and that's what we need to address with the perfusion or the preservation to get a better outcome. And for that we need to understand, and again, very disappointing, it's described since many, many years in high impact journals, but we just, from a surgical or preservation point of view, we're not considering it too good or too well until today. And when you then take this ischemic organ which has no energy and has accumulated so many bad things, and you reperfuse, you have a rapid release of these radicals. And that happens in the first minute. You cannot do anything. You can put it on a nice machine, long, warm perfusion, whatever. You will always have this. And this is your injury. And we need to look how we can reduce this. And if we find a method to reduce this, we will reduce everything else. Inflammation, 1,000 molecules released, immune response, cancer, and everything. And that is the problem. And it happens immediately. And this is just a slide which shows you have a few cells. If you have a good liver, you have a few cells, or a good kidney, you have a few cells which die and release their molecules. Those molecules then affect the healthy cells. And if you have a risky organ, more ischemia, older, fatty, you have proportionally more of these cells which have loss release and injury release. And then you must lose gradually your function and get complications. And that is essentially the same in all organs. This is a British paper, very interesting, because it's Mike Murphy who wrote that, and he's specialist in mitochondria too, and he shows the median cold storage in all those organs, and complications are essentially the same. If you look, a liver gets a biliary complication, and the biliary complication here is called bronchiolitis obliterans in the lung. So it's essentially the mechanism is very similar, and the result is a graft loss, for example. So we need to do something about those guys, like loss of energy and accumulation of succinate. So we essentially need to change something, either here or before we implant, and that is basically machine perfusion. If we look at the history, you see a little bit, it started basically 100 years ago, so Verne presented the first circuit to perfuse something. And then it goes on, and you see a long time we did cold storage successfully, then NRP was used clinically for uncontrolled DCD donors, and then in 2010, James Guerrera from the US published the first study with ex situ machine perfusion, cold perfusion at that time. And now we have, of course, more devices and many studies available. This is the landscape at the moment. You have seen the VitalSmart and Avid here, of course, and you have heard about many other devices from liver assist to OrganOx and so on. And in, I think, 5 to 10 years, this slide will be more busy. Some devices will disappear, new ones will come, and we will need better technology. I always say we cannot go under the table for a screen like this size and shuffle ice like a train conductor, and it is leaking. In a century where we fly to the universe, no, not really. I don't agree. If you just look at the setting, of course, there's NRP in the donor, and you started that here as well. Then you can perfuse to reduce the cold storage with warm perfusion, and then, of course, easier labor, less labor intense in the recipient center. And it's beautiful. Every study, every technique is perfect. I have the highest risk, and I have the best outcome. That's what I always hear. I do not agree. And if you see, for example, NRP is good, but there's no randomized trial yet. Okay, good, but it's still the highest level of evidence is missing. Normothermic, of course, these studies are very intense to do because you need to transport the device and you need logistics, it's cost intense. Ischemia free, we discussed yesterday a little bit too from the Chinese. It's also interesting, but you can also just take it out and implant directly. Why do you need to machine when your donor and recipient are next door? I don't know. Cold perfusion, certainly easy to do. Of course, the first randomized study on DCDs purely, and then the mixed rewarming and NRP and cold and warm and everything, because surgeons like to try things. Everybody likes to have a tool. That's my tool, and I try here a little bit, and so on. So the problem is we need to understand what happens with the different techniques. And certainly we have two leading normothermic devices at the moment used in clinics. You know them, OrganOx and the Transmedics device. It's essentially a reperfusion moved from the recipient to the machine, because it does exactly what happens in the recipient, but we don't have the other organs which can help us to get over the reperfusion injury. We just have a device, and we apply mechanisms and molecules. We look into like viability tests, what we do in the patient. And this is a slide essentially to show you how confusing the literature is. Because if you go and just to take these two studies, the Nature trial, clearly a leading trial in 18 published, and the other normothermic study, and you try to make your way through the important parameters, you see how inconsistent that is reported. DCD, you have a warm ischemia time, but in the other paper you have not even a warm ischemia time mentioned. How shall I then understand the results if I don't know the injury? The other thing, for example, here, the study is powered for warm versus cold, or cold storage versus warm ischemia or warm perfusion. And the results, they are frequently reported EAD versus no EAD. So it's out of the range of the study and the randomization. And then in the end, graft loss is equally low in the control arm. So it means it's good grafts, so why do I do it if my graft survival is the same? Both very important trials, but be critical. I'm also critical to my papers and my fellows, but this is not convincing what I read. I want to understand the injury, I want to understand why I do this. And then you move on and you see heart and lung frequently pumped normothermic. Interesting, because for DCD hearts, we retrieve the blood from the donor and we recirculate the old blood, which was sitting in the donor for 20, 30, 40 minutes. And then we wonder why lactate, potassium, everything is high. And no wonder. this cannot work in high-risk organs. It will work in good hearts. It will not work in risky organs because the mechanism is a reperfusion injury. And on top of it, you give them the parameters which are already elevated. That's why the colleagues who perfused the lungs, they went to an acellular perfusate, they reduced the temperature a little bit, they go a little bit down already, but still, if you go and look into the literature, you can see what happens. Here, you look at some of the cytokines, 1 hour, 6 hours, 12 hours, there's a significant increase. You basically get your inflammation, you know from the reperfusion injury, and you induce it and you see it on the machine, and that's what they call then viability assessment. So it makes sense. You need this to see viability in warm perfusion. The same as in kidney. Beautiful kidney, a little bit more injury, 6 hours, you see after 6 hours it increases clearly. And with the cytosorb, so additional €1,000, you can reduce it. If it's good, I don't know. It's not tested in clinic. But these €1,000 in addition, I don't know if it's needed. It doesn't change the outcome. Liver, exactly the same. More injury, you see here, 30 minutes, 60 minutes, warm ischemia, DCD model, increasing, and probably 50 other molecules also. It's exactly what we know, it's a reperfusion injury. And now, finally, this year, Chris Watson from Cambridge has shown us in a clinical study that exactly the same. When you have relevant cold storage before you do your warm machine perfusion with the organox or the other device, if you do it after cold storage in the recipient center, you get the same complications as if you do cold storage alone. So why should I do it? I don't know. I want an improvement. I want less complications. But I have essentially the same graft loss in the time period. And Chris Watson is a big fan of normothermic perfusion and NRP, and he did a lot of studies and perfused now more than 150 grafts. And he says that clearly in his recent papers. Another interesting thing is also this. We read the title, this year I read it, The Use of Normothermic Perfusion Rescues Liver Grafts from Extended Criteria Donors. Good, I'm interested, I read. And I go down in the abstract and I read, overall survival did not differ. Okay, so, I go to the next paper. Another problem, this is also some pictures from Zurich as well, because they developed this long-term perfusion, and also from Chris Watson again. The position, perfusing, when we think about how the organs are placed in ourselves, the liver is hanging, and it's very much dependent on the heart and the pump and the pressure and the inflow from the bowel and so on. What do? We take the organ out, we put it in the plastic, and we give a fixed perfusion flow and pressure on it, particularly under normothermic conditions. Liver wants to swim. And you see what happens. This is a mesh, this is a plastic mesh, and you see it even in the CT scan afterwards. You see compression, you see necrosis. It's not good. We need to improve the technology. And we need to tell the companies what we need, because they do not produce it, what we need. This is another paper confirming that from Peter Friend, and you see the necrosis in a long perfusion. If you have discarded livers with high risk and you perfuse long under warm conditions, you get your injury and you cannot turn the wheel back. And unfortunately, the same is also with this fantastic, beautiful device from Zurich. You see the liver is placed like on a... They want to simulate the diaphragm, and the idea is really good. They also replace kidney function with dialysis, hormones and pancreas and everything. And still, if you have an injury or a risky graft, you get necrosis. You cannot change that. Leider, unfortunately, a problem. And then you need this cocktail. It's like a pharmacist. 2-hour, 3-hour preparation for the perfusate. Antibiotics, dilating of the vessels, different fluids, thrombocytes, FFPs, red cells, everything. So it's very intense to really run that machine. And this is a room full of equipment, and still one organ transplanted, which was a domino liver. And if you want to use those grafts, which you can usually not use, you get this. So we are not so happy at the moment, but it's a good technique because you can explore new things, you can probably test new things in the future and in a scientific environment where you have money and interest in research. But for daily practice, to get more organs, This is a problem here. You get your injury, and when you start to treat, for example, defatting or vesicles, organoids and everything, you can start here, but your injury is there, and if it's a big injury, you have necrosis already, so your treatment is too late. Low risk, okay, liver will recover and you can perfuse long and try to improve something. That is the problem. It's very interesting, fascinating, but doesn't change our injury. And that's the reason why many people in new terms, this is just one of the papers, try to look into cold perfusion and to combine it, maybe cold first and then warm, or cold alone, maybe even better. And with this combination, they found and confirmed what we say and what others say many, many years already, since Starzl and Belzer's times, that you can achieve less inflammation with the cold perfusion. You see this, and I'm sure you know these papers. And if you dig here again, you see that they did long storage and long perfusion, because type and screen at these times for kidneys took a day or 2 or even 3. And they needed this preservation time to decide for the recipient. We don't know that anymore, we are not used to that anymore today, but that's why they tried to do this with this small and easy to transport the device. At that time already it's very similar, but that's what was in 67, 70 used. And this is one of the first papers from James Guerrero. You see him here, he's a good friend. I always think he's my friend on the other side of the ocean, fighting for the same with one of his livers. And in 2010 and 15, he showed already that you can reduce complications when you add cold perfusion to cold storage. Currently, these are the devices: Aphoretica, Liver Assist, VitalSmart, and the American device is placed in different ways. The organ, you see the mesh, which I don't like, I always cut it. I mean, I used all devices in studies apart from the American one, but I always cut the mesh because I want the liver to swim. I don't like this pressures. This is the easiest with the bowl. Liver swims freely. That's the American one, and that's partial graft. That's the Aphoretica, it sits in the plastic again. And it's very easy, it's not spectacular. Maybe that's also a problem, because humans always think if it's complicated, it's good. But it needs to be easy. We have a surgeon in theatre, you have patients, you have a tired team, you have anesthetist, you have relatives. And then you have a machine which beeps and leaks. Nah, easy. Easy, simple, quiet in the corner. And that's what we do. We do 2 hours minimum, or let's say 2 hours cold perfusion with ice, easy connection, portal vein only, that's enough. We have data for that too now. And low pressure. You don't need a high pressure. We always think, also for kidneys, we think, okay, kidney need a high perfusion pressure because physiologically the kidney has a high perfusion. No, we only want simple, the oxygen to go into the cells. And that can go passively in the liver for sure, to the portal vein only, and in very short time you achieve the entire organ. You see even the tip of the ureter you achieve in the kidney, and the tip of the common bile duct you achieve very quickly with this technique. A few examples we collected recently: fatty livers. We use also high donor transaminases, DCD livers, old age, basically everything which we think, oh no, I'm not comfortable anymore with this. Certainly every DCD liver. Also split livers are risky because they have a longer travel time, they're longer outside, due to the split, they have additional cytokines released, they suffer more. And why does it work? Very old, already published many times. It's easy. Less than 15 degrees, you have more ATP. If you reintroduce oxygen, so you reperfuse ischemic tissue, mitochondria make much more ATP if you do it cold, before warm, and you have much less ROS release. You see the ROS release increases significantly above 15 degrees. And it's as simple as that, because you change something significantly in mitochondria, which are the key for that. We measured all this for 8 years now. We have some experts who dedicate their entire life to one of those complexes, and they measure that and they can confirm that. And we see with the cold perfusion, we increase the activity of those complexes. We get 20, 30 or more fold ATP, and we reduce our enemy succinate, because the electrons jump and the TCA cycle works, and that's it. That's as simple as that. And then you can, of course, look at the inflammation, and you can measure all this. Here you see the ROS. We measured that in the perfusate once when we get warm later on, and you see when you do HOPE before, you can limit the ROS release and the inflammation, and you have more energy, and so on. You can measure many things. And then, for me, it's always also interesting, if it works in my hands, I also want to see it work in other hands. And it works in all organs the same. There's the papers on lung, kidneys, pancreas, heart, and everywhere it's the same. The biology, cells are the same everywhere, and much more smart than we are. And we try to confirm this perfusion quality also in the other organs, and you see the heart is also beautiful, and even the little I don't know, connections to the valves, even they stain green in short time. So it's getting everywhere in very short time. I've discussed with Marcus a little bit the oxygen today, and it's interesting because we still do not know on the life port, for example, had many years no oxygen for the kidneys, but only the oxygen which is in the fluid. And only slowly we understand that this is probably not the best technique. There's a randomized trial for kidneys now. Ina Jochmans was the lead there, and it's published in Lancet in 2020. And that's essentially confirming that with oxygen in the perfusate, you see it here, life port, kidney, you perfuse only with the oxygen in the fluid, you lose it very quickly, in very short time, because the organ uses it. And this is an interesting study below here, because you can clearly see normal fluid has 20 kilopascal, you don't get any ATP. Only with excess oxygen you get ATP back in the cold perfusion. So you need oxygen. If you have a life port, you need to connect it with oxygen. We do not perfuse, we don't need to perfuse 10 hours. 2 is enough, but oxygen is needed. You can easier better transport it quickly on ice and then put it on a proper machine and put real oxygen. And that's also in liver and in other organs. There's many studies on that. That is the kidney study I spoke about shortly. It's clearly an effect and a risk reduction for rejection and graft loss between cold perfusion alone and cold perfusion with oxygen. And this is randomized, you cannot get around randomized, although there's other problems probably too. And it's similar when we look at liver. This is liver studies. You see we usually have 4 to 15 hours cold storage and average 2 hours perfusion. And the outcome is the same in every of these studies. And it's understandable why, because they ask me how long, an hour, 2 hours, 4 hours. We see that the mitochondria are switched after 1.5 to 2 hours. Depends, of course, a little bit on the injury. But you can see here that the NADH is gone after 90, 100, 110 minutes. And the ATP is uploaded in 2 hours. And there's not much more change later on. And the same is with the bile flow afterwards. You get the same bile production and function with 2 or 3 hours HOPE before. So 2 hours is perfect to switch and to be safe from the metabolic side. And you can read loads of papers, but the effect on the biliary tree is now more and more confirmed, not only with mechanistical articles, but also with clinical studies, randomized, and you know this study very well, I'm sure. But it's also interesting that extended DBD organs have the same effect on the severity and the needed interventions of these biliary complications. This is a study from Turin, a single center study with more than 100 cold perfusions, and they have a median donor age of 76. Italy is the leader of all donors, and they have less complications, less major complications, less graft loss, and also less biliary complications. And the same we found in our randomized study with 10 different centers. It's essentially the same. We have less severe complications when we do cold perfusion after cold storage, and you can interestingly also discriminate that, because the recipient we cannot really change, it's given and I accept it or not, but I can only improve the organ a little bit, and if I pin it down to liver graft treatment and to liver related complications, I can reduce them almost fourfold when I do HOPE. And again, even in Germany is not the leading country for perfusion, it has no DCD program, machines are allowed only in studies, but they did a small randomized study and found even a cost-benefit. Cost analysis is not easy, it's always incomplete, needs to be done in different areas and repeated in all regions to really make it acceptable for the commissioners to pay for that, but they found also a reduction in complications and less costs despite the use of cold perfusion. And 10 years ago we have been shown the same in kidneys already, but we forgot it already. So we're not doing it routinely. So just a little bit mitochondria and oxygen, which is really cheap, reduce a lot, and it's not spectacular, but it's certainly interesting. And even people who focus on NRP their entire life, for example, leading countries, Spain, France, and also the UK, who say always, no, we don't need anything in addition, we have the best outcome again and the highest risk. No, we don't need additional machine perfusion in our program. But if you look now a bit more detailed and you see Spain, the absolute hero, 6 minutes asystolic warm ischemia. Italy has 20 minutes no touch. We'll never get to 6 minutes. Never. This is the French paper, 22 functional and 17 asystolic, okay? And in the UK it's the same, but they are not in that range where they would see a difference. And now after telling them again and again and again, they have new papers from the Hesheimer group, for example, leading groups certainly. Finally they saw, okay, I can do NRP with my low or short warm ischemia, but if I have too long cold storage, it's not good enough anymore, because I don't know where I am. I do NRP, then I do cold storage, and when I implant finally, I don't know. It's just there. And if I have 6 hours, 7 hours, 9 hours, at some point it's too long. Makes sense, because you have a reperfusion injury again. And here you see clearly the difference. Your recipient risk increases, you have lower outcome, your cold storage gets longer, you have lower outcome. So it's certainly not enough to do that. And the same in France. When you breach the protocol and have deviations, you have biliary complications, HCC recurrence, and PNF. Logically expected. So what did we do in Florence with Paolo Muisan as well a few years ago? We compared that in animals. We did an NRP model. You see the DCD liver. Here you see the NRP. It looks beautiful. It's like a DBD donor. And then we measured a little bit of injury and high injury. And you get your inflammation. It's clearly black and white. You see increasing injury, you get inflammation. And then we wanted to understand, is it maybe better if we do it cold? And yeah, based on what we've seen before from other studies, you have much less injury when you do it cold. It's expected, logically. So we will go and do a randomized study now, early cold perfusion instead of NRP, to see if we can make it easier and less inflammatous in risky organs. And this inflammation is also important in fatty livers. This is the Turin series from Italy, and this is the DCD fatty liver series from Switzerland. It's the only papers which were done with perfusion now, or shown at least. And there's some cases with severe macrosteatosis, and you have still an effect. But fatty livers are difficult, also because the biopsy is not reliable, the quantification techniques are not good enough. The macroscopic assessment is still the best for me. Sometimes you see fatty livers where you say it's a piece of butter and the biopsy comes back with 20%, and you think, never, cannot be. But it's like that, and the other way around, of course, as well. So we've done a little study in Zurich, I remember, and we gave the same specimen to 6 pathologists, but you get 7 opinions in the end. And not to blame anyone, it's not easy. But it's just like that. So we need more data for fatty livers for sure. And the inflammation is also important in the immune system and the activation of our immune system. We wanted to show if you do these little cold perfusion, you see a kidney, for example, perfused cold, and it's an allergenic model, so we would definitely do severe rejection, as you can see here, kidney recipients with untreated, no tacrolimus dying immediately. If you do cold perfusion, you have much better survival. The same in liver. Hope without any tacrolimus gets a big survival. So you have an impact with this little blocking of radicals. You have a significant effect on all the T cells. You see here the histology, the FACS analysis, just a few data. But that's what we would expect, and we see in a big surprise. I told my fellows, look into the clinical studies and see if there's an effect in clinical papers. And we've seen in the randomized studies and in retrospective studies, you have an impact. It's not that really what people are so interested in rejection, but there's a 10-15% difference, and it's really significant in some papers. Okay, less cost, less biopsy, less hospital stay, less increased immune suppression, so less later complications, less infections, benefit, less problems. Oops. And another question, we were looking into that also with Mazzaferro recently. Shall we really do that? Is it a good idea to have all these cancer recipients and to give them a DCD or an extended DVD graft, because they are usually medically better and they can handle the reperfusion injury? Is that a good idea? Do we not trigger more recurrence? So we looked into that with a cohort from Birmingham and from Switzerland, and we had quite a high number of patients outside standard criteria in Switzerland, and we always give them DCD liver since 2012. And with the whole procedure, we have had a much better outcome compared to the DVD control cohort, which is not perfused. So I think cancer recipients should always be perfused. And if in my sense in the future, I will certainly push for that. And we're thinking now into cholangiocarcinoma, metastases, all these cases are transplanted. I think they would benefit even if you have a short cold ischemia time. And another question you may have asked yourself, and many other people do that, is, do I really need to perfuse through the hepatic artery too? If I send the fellow for the retrieval and I have to do the bench and I have to connect everything, first of all, you can start the perfusion later, and then a cannula even near the artery may injure the intima or even the entire wall. I'm not so happy. So if we don't need to, I wouldn't. And anatomically there's no reason, because you have the same venous mesh around the tip or the entire external hepatic bile duct as from the artery. You have a venous mesh. You see that histologically and everything. And we've seen the fluorescein at the tip of the hepatic common bile duct, even with portal vein perfusion only. And now finally we have also randomized studies with artery and without artery, and the effect is the same. So I think there's no reason to really use that. And the advantage is this is done in France now. You see here the cannula nicely in the portal vein, and they do the split procedure and they keep it, and you don't need to do anything with the small artery. You can just do your split and perfuse, and then you protect both sides of the future recipients and take the first one, implant, the other one goes to the other center. So it's another advantage technically not to use the artery. And of course, happy mitochondria, better regeneration, mechanistical data on a better outcome when you do cold perfusion instead of cold storage only. So better regeneration. That's a little series from Birmingham. We did 15 ante and ex situm liver resections, and we did part of them with a perfusion, with a cold perfusion, to give the graft oxygen or the future liver remnant oxygen while we resect the cava and the right liver and reconstruct. And Italy did the same short series on that. So it's not only good for the transplant itself, but also for certain cases. Another short question I always hear is, how long can I perfuse? And if I look to my colleagues in Brazil and in India, they have loads of logistical issues. For example, in Brazil, the organ comes and then they do another type and screen. So the organ sits in ice for 2 hours, 3 hours, until they finish another time and screen round. This is by law, so they have always 6-8 hours cold storage minimum. And then they have a very bad donor treatment. We're not used to that, but they have donors with sodium 185 and nobody cares about it. And they do it, and they want something to improve it. And they started with the cold perfusion. And this is a study on longer preservation. It's just an accumulation of cases because we are just doing it and increasing the time, and the team from Robert Porter is now doing a prospective study showing that you can also transfer the the process of transplantation into daytime with a cold perfusion, and here you see some of the cases from Brazil and Germany with risky donors and long preservation time, and here even risky recipient with high MELD of 42, and yeah, you can do it, certainly. Feel probably a little bit more happy with the viability test, but you can certainly do it. Cold perfusion, I think it's easy. It's not spectacular. It's in the corner. Everybody can do it. The fellow can connect, no problem. But it's fairly efficient, and we have now evidence for many different things: complications, rejection, tumor recurrence, and it's certainly also cost beneficial. We need better data for sure. But the problem and the remaining question is, of course, and I'm sure you're very interested in that, if the organ is really, really good enough to be used. And that's what we needed to look into, and we did in the last 6 years. We wanted to understand, are we able to really have a good test? And for me, a good test is really like an ampoule. I'm a surgeon, I'm a visual person. I want it clear, I want it black and white, and I want it applicable in different scenarios. So a threshold, of course, should capture those. I don't want organs. When I measure in my perfusate and I have an organ which is below the threshold, of course I want it to work, and vice versa. And I think we all want the same. And I always read in presentations from my colleagues on big international symposium, I read, only normothermic perfusion can do. No, there's data in subnormothermic, and this is a sample from perfusates during cold perfusion, and we put it in the mass spectrometer and you can measure everything. The problem is to find the right one. This is from David Meyerhof from Berlin. He's working in the Max Planck Institute, and he's doing all these analyses every day. And yeah, and now, but this is 6 years ago, and we looked at each other, and now, which one is it? And he identified actually the right one. But markers in general should be specific, and we have many. We have histology, perfusate bile, tissue, we can do biopsies, we can measure blood gas, we can measure biochemistry. But nothing is specific, and those tests which are specific need a lot of time to have it. And I have no time. I'm perfusing 2-3 hours, I need to decide. I have no time. And many of these markers are derived from our clinical scenario. So we have a patient with liver injury or liver resection or even a acute liver failure. And that's where we derive our markers from, AST, ALT, lactate, clinical. But none of these markers is really showing us the real function of the liver. And that's a problem. We have not the right marker. And let's look at lactate, one example. Look at the literature. Lactate decrease, the best marker during normothermic perfusion. Yeah, papers. 5 cases, lactate threshold 2.5. 10 cases, threshold 2. Threshold 3, 1.7. 11 cases. If I want to start a program and I want a marker, we rely on it, which one should I take? And then I base my decision on 26 livers, and these are all leading groups. And of course it's an increase in experience and it takes time. But with this, it cannot work. I cannot. I don't know. And we all have seen liver recipients with a lactate of 5, sitting on ICU, perfectly happy, everything else normal, just the lactate needs a bit more time to get down. And the same with the coagulation parameter. So this is certainly just one parameter, but not the most decisive one. And the same is also with the biliary chemistry. This is the most recent article from Groningen. Robert Porter is a big fan of the biliary tree. And you have 7 parameters. Beautiful. And all can be in the green zone, orange zone, red zone. What do you do then? Let's say 2 are green, 3, 4 are orange, and 2 are red. Yes or no? You need so many cases to really understand, and he respects this and still has coagulopathy. So it's certainly only a part of the coin, but definitely interesting. And we measure here. If you look at the tree, this is where we measure. But we should measure where it starts, basically where the injury starts, because that's the key. The decision if a graft will be good or not is in the mitochondria and not in the parameter lactate. So our mitochondria friend in these times, found a marker which is already known since many years and been published since 1969 or even 68. And it's actually a vitamin B2. We can also say FMN, flavin, mononucleotide, and it's in all of us, in all our complexes one, it is sitting here. And it's the key site of ROS release. So when you give oxygen back, the radicals come out, and also FMN H2 comes out and reacts, and so it's coming out as soon as you give oxygen back, anyway, in any time, warm, cold, subnormal term, always. It's released, it's going in the perfusate, and you can read it. Because it's beautiful, it has an autofluorescence. You just can take the perfusate, pipette it in a plate, in this N96 wire plate, and put it in the spectroscope and read it. We found one in the lab here, which has the wavelengths where you can read it. You just can take it, pipette it, no agent needed, no expensive test, just read it. And it was also found in the brain. So this was data from the heart. So it's not only in liver, it's in every organ. And what did we do? In Zurich, we started our perfusion program in 2012. And the first 55, 60 grafts we transplanted, all DCD livers. We measured, when we identified FMN, we measured it, the perfusate, and correlated it with outcome after transplantation and graft loss. And voila, FMN predicted graft loss clearly, and retrospectively we identified our threshold, and you see fairly clear everything beyond it was lost, and everything below survived beautifully. And it's not, you cannot say that it doesn't predict non-anastomotic strictures, because also non-anastomotic strictures were beyond the threshold. And since this established threshold, we follow our marker, and we validated it also in these samples. You see this is 7 different centers in Europe and US, collected, again, perfusate, pooled it, measured FMN, and confirmed the data. And this is experimental studies in other organs, so you can measure it in any organ. We just need to identify the threshold and link it to clinical outcome, of course, what we measure in our perfusate. And in the clinical setting, imagine now we get an offer, DCD liver, at a certain age. We have no cutoff anymore. We have no age or any history cutoff. We just say yes. We retrieve the organ. You see here, we can also measure it in real time, online now. In theory, we have the VitaSmart, we have a clip-on sensor, and we read it online with a little spectroscope. It's now established, and I think next year this will be available. And you have a liver, for example, this one, 69, 24 minutes warm ischemia time and macrosteatosis. Well, I must say 30% is probably too low for this piece of butter. And then 19-year-old donor, short warm ischemia time, looks good, looks nice. Then you have a 78-year-old, that's a typical Swiss graft, 70 minutes functional warm ischemia time, all the three. And now my instinct would say, okay, this one, beautiful. This one I would reject, this one I would not take. Now let's see what happens. We measure the fatty one, does what is expected to, it goes up the roof, beyond every threshold you can ever put. And the young one, beautiful one, has a lot of injury, and the recipient had a lot of inflammation. And the old one, we would never expect, was beautiful, like Cadillac. You cannot say, yeah, recipient on normal ward on day 1, perfectly fine. We cannot say it just by looking at it. And my colleagues always say, I hate to hear, oh, this, do you do it? I do it when I can measure. I wouldn't trust everyone. But I see frequently younger livers with short warm ischemia, also 40, 50-year-old donors, because the problem is we try to save these people. We put them on ICU, we treat them long. They have 8, 10 days on ICU. The organ suffers, it's getting more fatty. You have ischemia already with high inotropes. These organs are worse. All donors with a brain infarct, ischemia, what can the liver do for that? The organs are good. It's metabolically in that case. And that's what we do, and that's the effect, and one of my last slides. That's the effect if you look at the DCD donor utilization in the last 10 years in the leading countries. It's very interesting because DCD livers is actually a small proportion. If you see Belgium and Netherlands are leading, France and Italy, very little. UK always says we have lots of DCD, actually only 20% of the transplanted organs, in US 6%. And then if you really look at the utilization, so first telephone, first offer, not what I look at NRP or what I have and I do it. No, first offer. It's getting very poor in some countries, 89%, 27%, and those countries with routine machine perfusion have the best numbers, to be fairly honest. Even Spain does only 50% perfusion of organs routinely, you see that here, 50% NRP, and with a low risk. But this is very interesting, and that's what we actually do. We see FMN, and you see different gradings. We can not only predict a graft loss, we can also predict that recipients get more inflammation and maybe a kidney injury, maybe a little bit of dialysis. And it's not only a black and white. We see clearly that if you are, let's say, between 5,000 and 7,000, in the first 30, 45 minutes, you see and you can say, okay, this will be a bit of a kidney problem, a bit more treatment. So it's really not only a yes and no. And spectroscopy is used increasingly in other things, for example, also for fat quantification or perfusion quality quantification. So we can use this simple technique for many other things. And that here is very interesting because if you have this, you take the perfusate and you measure very high FMN. You can also look into the tissue, and when you start your cold perfusion here on the left side, you see that there's a lot of green, so a lot of FMN. All the complexes are good. You start, and when FMN comes out, you have an injury and a loss of FMN. And at the same time, you have a high inflammation in the tissue already. So 5 to 10% of livers are not, hope is not good enough for now, and you decline based on that. But you see the correlate, it's really in the cell, in complex one, and we can look into that. And of course, mitochondria are interesting for many other things. Even colleagues from Italy and the US, they test various things because people want to play with the machines and with the organs. So we can, of course, also treat organs in cold perfusion. We just need to know the dosage of the particles, all the stem cells, all the silencing RNA, all the vesicles. We need to know the dosage and the timing, and then we can, of course, treat it. And what I see in slides from other colleagues is, of course, not right, that only. If a slide starts with only, I'm already lost, because only and absolutely is not true. It's like in the multiple choice question. This is always wrong? No, that's the question which is always wrong. And there's many papers, we don't know it, but if you pin it down what you can do, there's a lot explored. And mitochondria are transplanted, for example, in babies with cardiac failure to improve the function, to bridge the function. And you can do research in 10 lives with this, alone with this. And in summary, I would say, okay, we all agree that perfusion and oxygen is better than only cold storage. And I think also looking at the entire world and what problems we have in other countries, not only in the Western world, we should definitely balance the effect of the perfusion and preservation with the costs we have. And we see, and there's a lot of data now on that hypotonic perfusion protects from these complications and reduces costs, and that this modern technology is probably able to prolong the preservation, so we can go back to what Starsel did with cold storage in 30, 40 years ago. And we need certainly more work on costs and viability assessment, and definitely we need to collaborate more with those people who develop the devices, maybe even develop something on our own, because that's what we can then use properly. Because I want a small device which my small Indian colleague can take to the donor, can perfuse there, can read the viability, can send the organ somewhere where you, for example, don't have an assessment, or where you have a time problem. And we will have, with these internet and all the modern technology and the options we have today, we can tailor really the preservation in the future. And these sophisticated new devices for normothermic long perfusion maybe have a place in a scientific environment, in a university where you test new things. Maybe we test artificial organs in the future or treatments in the future there, but it's very difficult for a routine practice with all these costs and implications it has on logistics. And many people were involved in the last 15 years in this, many samples, many sufferers, sleepless nights, and in many countries, and I'm entirely very grateful for all of them. We're still fighting together and collaborate together worldwide and try to find the best preservation for our organs. And this is the early morning dawn in Milan, and that's what I feel. It's only the start, although I worked 10 years on that, and Stasler spoke about it in '65. It's only the dawn, and again, it's a great pleasure to be here. Thanks a lot for having me. It's nice to meet every one of you and to collaborate in the future. Thanks a lot.
Thank you very much for a fantastic presentation. I think we have a vacuum or of knowledge here that you are filling very just. Has it been any problems to introduce the procedure? I mean, at the OR. What strategy have you had to?
I can explain what we did in Switzerland. It started in 2012 because the hospital was interested to start a DCT program as in other countries, and we said, okay, we do it, but we need a machine. And we brought a theater. I know it was the 2nd of January 2012. Everybody's still a little bit in New Year's party mode, and we brought the machine and we started. And it was initially, it's totally on us surgeons to do it. And that's probably the problem in many places, because you need labor, you need someone. The nurses were great, they adopted it, helped us, supported us. But now it's easy. Now if I don't bring the machine, it's like, where's your machine? Oh, no machine today? And I've seen the same in the UK. When I moved to the UK, it was the same. You have no strategy. You want to do something good for your recipient, you have to do it. It's easier in scenarios where you have registrars or dedicated fellows for research or for transplantation or either you share it or because you have no perfusionists. I've not seen in any place the dedicated staff for perfusion of organs. Yes, in cardiac surgery, of course, but you have nothing in transplanted for organs. Maybe that's the future. When you have big centers and you perfuse all organs, you have people who really do that, which would be ideal because they know all the devices and they quickly do it. But at the moment, it's like we help each other. So my colleague in Brazil, when he started, we made WhatsApp screen. I was there, and we WhatsApp screen. Now measure FMN. That's good. And my colleague from the company said, okay, you need to change this, and thanks to the technology. But a strategy. We were writing a paper about obstacles recently, and it's not easy. We need to convince the commissioners with good studies that they pay for it. And then when we collaborate with the other organs, like heart, lung, and kidney, combined, we may improve things in the hospitals to get a strategy and like a pathway how to do it. Then you get your perfusionist. Once they see the benefit financially, you get the perfusionist because you can earn and afford the salary for the perfusionist and still have a benefit in outcome.
And in your general practice, how big percentage do you perfuse of the livers?
It's in Zurich, the DCD livers, we perfuse all DCD livers. This is, let's say, 30%. Then we perfuse everything else which is extended, so I think we perfuse at least 50-60%. If I look at other places, it's much less. Turin, for example, a center in Italy in the north which perfuses a lot. They do all extended, and per age every organ is extended already. And DCD is a small proportion, but I think they do also more than 50%. And then you have others, of course, with 2 or 3. I mean, you did roughly 30 in 2 years. That's good.
Yeah, but it's still
that's quite good.
15-20%.
Yeah, but it's good still.
But we should do more.
I mean,
well, we don't have that many.
Just take those 30 cases, match them with 60, look at the costs, and you'll do it. I can guarantee you.
We have one student there, Gustav, is going to do that. Questions?
No, just a comment. Thank you very much today for this excellent lecture. It's been great to hang out with you last night and then also today to take you around. We had a visit to the lab here and we found a spectrometer, so that's great. We'll set that up soon. And your lecture definitely answered a lot of questions, but you also new questions come up. So I think I came up about square on that one. But it's good, it's great, and I really hope I've got your phone number. I'm going to use it because I'm going to need it, and I hope maybe I saw Gothenburg, a dot on Gothenburg here on the
Yes,
Yeah,
yes.
we were there. That's good.
Yeah, we were there. That's great. Maybe you put it there today or last night. But we really need this.
That would be great. You have, I don't know if you stored your perfusate from those 30 cases. Maybe
No,
not.
we haven't.
But we can
We'll
certainly
start.
analyze and integrate.
Yeah, no, I think that's...
We have a big community. We have now US, we have Brazil, we have India. In India we started, they have in 4 centers, they do it, we all...
We're right
try to
behind India,
collaborate.
that feels good.
No, you're ahead of India, actually. The 31, you're ahead.
I need to run, but
No problem.
thank you.
You are?
Yeah. Okay, thank you very much for the update, really. I have a specific question. What about stem cells and progenitor cells? I mean, those are more resistant to ischemia and perfusion, and they must be important in the repair process, even in the short time frame. So is there a lot of focus on that? Can you support the progenitor cells and repair better?
You're absolutely right. I couldn't agree more. We think and we see, and there's mechanistical studies for mainly also in the biliary tree, that the progenitor cells help to regrow the injured cholangiocytes and epithelial cells. And what we see is, and Robert Porter looks into that with the cold perfusion and his samples from his randomized study, that when you protect, of course, with the oxygenation in the cold, you also protect those cells, and then you have, that's why less biliary complications and less strictures and less inflammation. The problem, I like the idea to inject stem cells on a device, but again, we did in Birmingham a study on that under normothermic conditions, and the idea is good because they go, it's warm, they can find their place effectively and work. The problem is, again, you inject the stem cells in the environment which is already very inflamed, so they can only do they do what they can, but they can only do a limited job. So I don't know how good only the injection of stem cells will be. It will certainly help, certainly bridge maybe in a very acute situation where you don't have a graft maybe. Also the organoids are interesting to do, but we should try in the
But even preserve the endogenous ones.
Yeah. It's true. It's just that if the injury is too high and it starts right away, even if you give the stem cells before and you do warm reperfusion directly, the effect is not should be higher. We should do cold perfusion. That's why Robert Porter does this combination cold and warm, because with cold you can at least treat a certain percent of the graft, and then if you want to treat, the team in Zurich who develops this long-term perfusion does also do that. We always cold before, and when the criteria are not met, so the FMN is too high, then they put it on the long-term machine, and then we know it will. We can test that treatment, but.
Thank you.
Karin?
You mentioned that you add oxygen to the life cord machine. Does different organs need different amount of oxygen? Lungs, for instance, do they need more liters?
That's a very good question, and many people think about that. I think the lung has a big advantage, because you also in DCD donors, the donor is extubated and re-intubated, so you give oxygen back to the lung very quickly. I think the tissue, the cell itself and the mitochondria, they react to the higher level of oxygen. Now what we saw in this one of the studies, when you give, let's say, more than 300-400 millimeter mercury in the perfusate, or 60 to 80 kilopascal, then you see the big effect in ATP. Because then you offer more than the organ uses. I think I have not seen any study where someone compared the different tissues with different oxygen levels to see that, to fully answer that question. But I think the cells benefit from high oxygen, and in the cold, we certainly have no radicals, because we're always afraid when we do too much oxygen under warm conditions, we get more radicals. In the cold, no. Full speed, I always say when we put the machine full speed, 10 liters, full on, and you get your effects. You get what you want.
Selma?
Thank you for this very elegant talk. I'm not a surgeon, a nephrologist, so let me ask you a very naive question. You showed that the FMN levels, they predict the function of mitochondria. So if the levels are high, then the outcomes are better. I mean, can one do or has one tried? How about giving or including high levels of vitamin B2 in the perfusion fluid? And does that somehow affect the outcomes? I mean, does it work on the mitochondria in the reverse way?
It's an interesting point because vitamin B2 is essentially the molecule in the complex 1. What we've seen that when you have high release, because it's released from the complex 1 in the perfusate, then your outcome is worse.
Yes. Oh.
Because when your concentration is higher than a certain threshold, we know graft is a high chance to be lost, and we don't do it. What we also see, and what the mitochondria specialists suggested and say, is that FMN can reintegrate into complex 1 when it's going, but there's no data on that. So all these treatments we are now exploring, we are also using this system of FMN and the TCA cycle, the respiration basically, to test all these treatments like metformin, Mito-Q, all these different treatments to see how can I improve those organs which I cannot improve enough with the cold perfusion alone. So do I need to go earlier? Do I need to do it initially up front? Or how can I do that? And that's why we are looking into this together with the FMN levels as well. Because it's really interesting when we have high injury and we give, let's say, a complex 2 blocker, which stops the electron flow. FMN goes to the roof immediately. So you can really, it's very, very sensitive. And you can, in an isolated organ, you can really, really beautifully assess all that. And we're hoping to come up, because we need a better solution too. The perfusion solution is not, the storage solution is not the holy thing. It was good the last 50 years, but that's it. We need to improve that. So that's, maybe we can add something into the solution right away in the donor, which prevents a little bit this injury already and competitively blocks something where the ROS release comes out, but needs a bit of time to have that ready.
So I think that we will continue with questions when we have drinks afterwards. But we might not be that excellent in perfusion, but we are quite good in some design things. We would like to give some presents to you.
I'm already here as a present. Thank you very much. That's nice. Thank you very much. Thanks a lot.
One from the university and one from the
Stiftelsen. Thanks a lot. Very nice.
Thank you very much.
Thank you.
First, I would like to give the floor to Sonja Grasin, who gets this new transplantation. Hon ska titta på its polymer mixture in languages. New transplantation efter genomgången behandling för myelom och andra plasmaassocierade sjukdomar. Och Sonja får 50 000 kronor som en startlån på sin forskning.
Thank you, Per. And I would like to thank Transplantation and Transplantationsstiftelsen for this opportunity to start this prospective multicentric project in collaboration with the hematology clinic, renal clinic at Sahlgrenska University Hospital, but also other renal and hematology clinic in country. What we want to look at, it's not a reperfusion injury, but it's a clinical topic. It's our patients who have a plasma cell or B cell, pre-cancer or cancer hematological diseases who finally get kidney transplantation. As we know now, the results of this transplantation are poor. They get very early recurrence of the disease, and we also see the patient death. What we want to do is to try to diagnose the early disease recurrence with the protocol biopsies at probably 6 months and 1 year, protocol biopsy of the kidney and protocol biopsy of the bone marrow, so that we could be able to early diagnose the disease relapse and find the best treatment modalities. No results and no protocols exist today in Sweden or in Europe or in world, just a little retrospective studies mostly from the US. So this will be a prospective study, as I said, with 3 years follow-up. And thank you again.
Fortsätter vi till nästa pristagare som är Helena Tafin som ska titta på kolorektal cancer och den hanteras med genamplifieringsteknik.
And I got 3 minutes for this. Well, 5-FU is the most common drug used in colorectal cancer, and we use it for shrinking the tumors and for reduce the risk of recurrence, and to when you have a palliative situation, even what do you call it? Prevent the progression. The mechanism of 5-FU is in the enzyme thymidine synthase, but thymidine synthase is a very complex enzyme, and we have lots of oncogenes before the thymidine synthase enzyme. And an oncogene is a gene that normally stimulates cell proliferation when needed, but if it's mutated or amplified, it leads to tumor growth. And we have seen that we have mutation in the oncogene types, and that can affect the cancer cells' mechanism in defending itself against 5-FU. So we are going to look at primary tumors, this is awful bowel cancer, and awful liver metastases, and compare the amplification and the mutations in these genes. And we can correlate it to whether they have treatment with 5-FU or not. And we're going to analyze it with a very wonderful machine that can analyze with digital droplet PCR. And we're also going to use fluorescence immunohistochemistry. And well, this is my belief that the future is soon here, that we should actually work with personalized cancer therapy, because we shouldn't give people 5-FU if they are resistant to it. So I think it's going to be a dark and cold winter, and thanks to this wonderful scholarship from the Stiftelsen for Transplantationsstiftelsen, it's going to be a little bit lighter. Thank you.
And we continue. And then I'd like to invite Sema Baid-Agrawal. She's looking at the donor-specific antibodies after kidney transplantation and the appearance and what happens for the long-time results.
So we are actually already have a project ongoing where we are looking at the donor-specific antibodies in these patients. And the reason for this is because we've come a long way, as you all know, with kidney transplantation. The short-term survival has improved significantly over the last decades, but unfortunately, the long-term outcome has still not improved. So we still see about 40% of the kidney transplants are lost over a period of 10 years. One of the most important causes, a major cause, is antibody-mediated rejection, which is mostly induced by donor-specific antibodies. So how can, and there is no treatment available for this kind of treatment, for this kind of rejection. So the best way would be to identify this rejection early on, before the irreversible damage occurs. And that's why we are trying to identify in these patients, looking at donor-specific antibodies as well as other biomarkers, the subclinical antibody-mediated rejection. So this is before we see any rise in creatinine, before we see any irreversible damage, to see if we can treat this rejection and make a difference in the outcome. To be able to identify, we need to do prospective screening of these patients, not just with donor-specific antibodies, but also apart from the routine biomarkers like creatinine and other things, we would also like to look at some other exploratory biomarkers like donor-derived cell-free DNA, which is one of the most promising biomarkers which has emerged in the recent years, and also some other. Oh, now we got it. So I can actually go back to the what I was in the background, and so I already spoke about the first. Oops. So first couple of things, and it's routine monitoring for donor-specific antibodies and graft biopsy, as well as other biomarkers such as donor-derived cell-free DNA, which I already talked about. In these patients who have donor-specific antibodies, this may allow us the subclinical detection of subclinical antibody-mediated rejection, also better risk assessment of these patients, which patients are at risk for graft loss and which are not, so who should be treated, and which can lead to early and individualized intervention in these patients. So our main questions are to look at in the whole group the incidence of donor-specific antibodies after transplantation and their impact on the long-term kidney and graft survival in our population. Look at the incidence of subclinical and clinical antibody-mediated rejection in these patients with donor-specific antibodies, and also what is the impact of subclinical rejection in the graft survival in the long term. In clinical, we already know that it has worse outcomes. And also, we would like to ask whether a composite of biopsy in these patients who have donor-specific antibodies together with cell-free DNA and other biomarkers can allow better risk prediction of graft loss in these patients, so that we can treat these patients, like have targeted therapies for these patients. And we would also like to explore some other biomarkers. So this is briefly the study design. So we plan to include this. The first part of the study is already ongoing, where we have already collected samples in patients who received a transplant between 2010 actually and 2015. And we would like to continue this further. Okay.
We need a pump.
So we would like to screen all the patients until 23, a cross-section analysis, and identify those patients who have donor-specific antibodies. We anticipate from over 1,500 patients total, we anticipate the antibodies to be positive in about 150 patients. And on these, we plan to do a biopsy, and in addition to the other routine as well as the exploratory biomarkers. And those patients who have either subclinical antibody-mediated rejection or clinical rejection, they will then further go to treatment. So right now, we do not have any specific treatment for these patients except for optimization of immunotherapy. But we also have an ongoing trial or investigator-initiated trial, which is called INTERCEPT study, where we are using tocilizumab, which is the anti-IL-6 antibody for treatment of these patients. So there may be a possibility to include these patients in this ongoing trial. So this is the whole idea, and we have already received the ethics approval, and we are ready to start very soon in the study. So I thank you all very much again, and the Transplantationsstiftelsen for providing this grant. Thank you so much. Sorry.
And Helena and Sema, they are getting 75,000 for their research.
Hej! Jag heter Elinor Wisén och jag är narkosläkare på Biva. Tillsammans med flera kollegor så driver vi en klinisk randomiserad prövning på operation som gäller patienter som opereras i levern. Titeln på projektet är, och nu måste jag läsa innantill, Influence of argipressin on blood loss and inflammatory response during hepatic resection, a randomized controlled trial. Vi har tidigare gjort fysiologiska studier på den här patientgruppen där vi har sett att vasopressin kan styra blodflödet bort från levern. Och vi gjorde innan pandemin en pilotstudie kring det här projektet för att se vilka mätpunkter som var mest intressanta och att vi kunde helt enkelt genomföra protokollet. Nu har vi gått vidare med den här kliniska prövningen och syftet med den är att se om vi kan minska blodförlusten under operation. Dels för att vi ser att blodförlusten påverkar återhämtningen efter kirurgi och också för att man ser att blodtransfusion kan öka risken för återfall i cancer. Vi planerar att inkludera 248 patienter. Hittills har vi fått in ungefär 35 och med den här takten så räknar vi med att avsluta projektet i december 2024. Vi är jätteglada och tacksamma för att vi har fått det här bidraget från Transplantationsstiftelsen och vi hoppas att vi kan återkomma med resultat från studien under 2025. Tusen tack!